Good morning. It is Saturday. I have no makeup on, but I've been inspired to give you some information, and I feel like it would be beneficial for some of you to see if we can get 99309s to 99310s. Some of the nurse practitioners are writing one line or two line HPIs, not appropriate. But if you get into a bigger documentation and you see some of the other nurse practitioners' documentation, you'll be able to see how easy it is to change your 99309s to a 99310. It's the difference between 4 RVUs and 6 RVUs, but it's also the difference between identifying what's going on with a patient and having a note that's very thorough. So on a Saturday morning, as I'm doing my documentation, I was inspired to take my pajamas off, put my clothes on, grab my coffee, and do this. So we're going to start here. First, it's not the same system that you use. Everyone has a different system. Pain management has a different system. Psych has a different system. However, it's in the same type that you'll see. And what I was trying to do was maintain the ability for HIPAA to not show you who the patient was. So this patient, chief complaint nausea, my assumption is going to be your assessment and plan is going to be nausea. It's an 80-year-old female, primary diagnosis of Parkinson's, and a significant history of UTIs. Medications reconciled, vital signs reviewed. This is a generic snippet. If you do not adjust it, it is not accurate. So blood pressure log reviewed, therapy progress reviewed, labs reviewed, and the patient is not diabetic. Last blood sugar was on September 5th, 2024, and it was 117. So stable patient. So follow-up TSH improved and within normal limits at 4.180. So she had an issue with her TSH and it looks good. An appointment with an endocrinologist is still pending. Follow-up TSH to be obtained. So she's addressed that TSH issue. Could you put that up here? Absolutely. There's no new information as far as a plan. We're still waiting for that. Patient, now she's talking about the patient as she sees it. The patient is alert, moderate confusion at baseline, sitting up in her chair. She reports having nausea, and we will initiate Zofran to be given every 4 hours as needed. Does that need to be in there? No. You could even write patient to start on Zofran, easy enough. The patient has a diagnosis of progressive dementia. I might put that in a different paragraph just because that's me. Of dementia with orders for donepezil therapy, which has associated side effects of nausea or vomiting. Now, she had been on this for quite some time, but new nausea and the vomiting. So he's going to change, the physician is going to change the medication to Zunveil instead of the donepezil. So then she also makes mention that the patient's on Cymbalta. She has episodes of tearfulness and sadness, but is redirectable with conversation. So psych team is following her. Psych team is aware of this, but easy to redirect. And I know this patient personally, and she does. She just starts crying, and then you talk to her, and then she feels better. So patient is being followed by PT for active range of motion, functional range of motion to the upper left extremity from her shoulder to the fingers, full weight bearing to her left upper extremity. So whatever was going on before in all of those previous notes, they've decided to address that issue. So patient continues to be at risk for falls. Why do they put that? Because she's had a history of falls and they want to make sure that this note reflects that she's had falls in the past because of her diagnosis, which would be Parkinson's, her poor safety awareness, her impulsivity and not being able to use the call light and wait for assistance, and her weakness. This includes, and so they're including these diagnoses, dementia, Parkinson's, unsteady gait, and history of previous falls. So they've addressed the fall issue. She hasn't had a recent fall, but they have address that she's at risk for falls. She has a posterior tilt to wheelchair to improve seating. She uses a wheelchair to get around, which means she's able to self-propel, and then a posterior tilt to a wheelchair frame for improved seating. So here you've got this posterior tilt to wheelchair frame for improved seating, and then you've got that here. Easy enough to delete. I'm working on that. So as far as her Parkinson's, she has blunted affect, hypophonia. She's very, very, very soft speaking. She has no tremors, bradykinesia, rigidity, no hallucinations or dyskinesia. Her current weight is 105 pounds with a BMI of 17.5. So that's of significance. I might have even put a patient with a BMI of less than 21 increases the risk for morbidity and mortality. She's being followed by the registered dietitian. Why do we care? Because her weight is 105. She may not trigger for significant weight loss, but her BMI is 17.5. So she's being followed by the RD. She's got MedPass in place. She's got Remeron to help stimulate her appetite, and she's on health shakes to promote adequate nutrition. So then underneath here, you've got your past medical history, surgical, family, and social history. Notice that these are not noted. These are actually pulled from either the patient's history, the family's history, the HPI, or the H&P from the hospital. So as soon as you get this in the computer, it goes from note to note. So it is worth the extra 2 or 3 or 4 minutes to search that out. That way it's always right, and it never just says no tobacco, alcohol, or illicit drug use. Because at some point, someone, whether it's me or the Upper City auditors or the RAC auditors, are going to say, this is not a comprehensive social history. So if I just go by, and I think I've done this multiple times. Usually I can just type it down here. Maybe it's because I spelled it wrong. Social. Here it is. So in order to qualify for a social history, so you guys have focused on tobacco, alcohol, and drug use. That's one aspect of the comprehensive assessment. So living situation, that could be their marital status, occupation. They could be retired. You may not know that. Religion, huge part of that. You don't have to put anything other than just their religion. Nutrition, dietary usually gets sleep patterns, mental patterns. The psychiatry, psychology gets that. Safety, risk assessment, hobbies. But you need to have more than just the tobacco, alcohol, and illicit drug use. Okay, so allergies, penicillin, co-status, do not resuscitate, and then her vaccine status. Medications don't dump into this thing per se, so reviewed in the EMAR. You've got your vital signs, your weight, anything that is abnormal is always or usually in the front, weakness, fatigue. She has cachexia, she's 103 pounds at this point. She's got nausea. I would put that at the front. I'm not saying it needs to be, but I would have put it in the front. The fact that it's capitalized indicates the fact that it needs to be reviewed on the next evaluation. The patient is incontinent at bowel and bladder. The patient has weakness, extremities normal, no edema. She's got thin and fragile skin. She has confusion. She's got tremors. She's got bradykinesia. And short-term and long-term memory deficits noted. So if I were to pull her MDS, which is over here, and I don't want anyone to see it because it's got her name on it. If I scroll down, I've got a BIM score of 11. So anything other than 12, 13 indicates memory impairment, and she does indeed have that. So labs ordered and labs reviewed. So I think I showed you this on the last one. 99307, we don't really use. Let's just say we don't ever use it. It's just saying there's something wrong with a patient. 99308, 2 self-limiting problems, or 1 stable chronic illness. Why are you documenting on 1 stable illness? This may be your patient that has dementia, that has no weight loss, no falls, no medications, no blood pressure issues. So if you needed to use this, you could. Otherwise, the 99308s kick back to me so I can find out if they actually meet criteria for that. So review of lab tests. If you have a lab test that is of inconsequence, you don't need to do a 99308 on that. You're going to wait until you hit your next evaluation. So for a moderate, and we're already bringing this up as a moderate, you've got your 2+ stable chronic conditions, and then you've got 2 data categories for independent historian tests and external discussion, as well as you have your collaboration. So that's usually what we go by, is the collaboration, or the external discussion is what it says right here, but that's our collaboration. And then they have to be at moderate risk. So you've started an antibiotic, you've started a medication for it, but they still have 2 chronic illnesses that are stable. So that's how you can get away with billing a 99309 appropriately and per the regulation. Now let's take it a step higher, because I'm telling you how to change it from a 99309 to a 99310, 310. Now you need to have an HPI. Your HPI needs to address these issues that you're working with, that you're saying needs a higher level of care. So you've got 1 chronic illness with an exacerbation, with a progression, not the same thing, progression, or a life-threatening complication. Or you've got 1 chronic illness or injury that poses a threat to life or bodily injury. I'm going to bring one of the nurse practitioners' information back into this setting. She had a patient with 3 gangrenous toes. That was on Thursday. She did send not only the cardiovascular, which I thought was great, the wound team information on this, and they were able to visualize this wound. This wound they classified as stable gangrene. On Monday, she came back, all 5 toes were black, and there was red up the bottom, the top of her foot. This was not a stable condition, and this is at risk of losing a limb. This was a high emergent thing that took the facility another 2 days to transfer the patient out after our nurse practitioner was begging for this patient. So whether the patient loses a limb, I'm not sure on that, but that's a huge, huge, huge red flag. If you've got a patient that they got the gangrene and you've got a doctor too, a cardiovascular and a wound doctor that's saying, no, it's stable. And you feel in your heart of hearts that that's not stable. And not only are they going to lose their toes, but could potentially lose their foot all the way up to their tib fib, all the way up above, and have an above the knee amputation. This is where we come in, and documentation is key in this. Moving on, tests or documents that or an independent historian. So you need to have 2 issues. So you have to look at prior notes. That's the first thing you're going to do. You're going to review any tests. So if they've had labs done, you're going to review them, and then you're going to order a test. So I wouldn't order a test just to order it. I would order a test to show that. I'm trying to get one that's light enough for you guys to see. I might go back to the yellow. Except for it's not letting me. Okay. So in ordering the test. So if you have a prior note that you've read, if you have a lab that you're reviewing and you have ordered your test, that's one part of it. Now it's saying and or you've got a historian that's making note to it, interpretation independently, and or discussion of management, testing, external physician, or a qualified source. So that would be your collaboration. Okay, so this patient automatically had a TSH issue. We noted that above. Why do we note it above? Because we're noting it below and we're taking credit for it right now. And then on 5-8, somebody forgot to write the follow-up on 5-8. We obtained a TSH as well. And then on 5-7, we did an alkaline phosphatase. And a B12. This may be the most important part that you're documenting on. Labs ordered, labs reviewed, throw back up here what progress note was reviewed. So as I look into the patient's miscellaneous, I'm looking at a neurology consult. They've had a dental consult. They had a psych consult. We specifically said that. They had a consult for hypothyroidism. So here we say up here, an appointment with an endocrinologist is still pending at the time. We're going to write has been completed. Just because somebody didn't look at the notes. So we can use any of these notes that we want. I'm just going to write progress note review. Me, most likely, I'm going to review them all. You guys are in a hurry. You're trying to get done. So I've automatically hit that. So what's our first problem? Gastritis. The patient had nausea and vomiting. The assumption is it's the donepezil. It's unlikely the donepezil. She's been on it for years. But that's what they're saying. So start the Zofran. Dementia progressive. We are not monitoring closely. These are snippets that need to be deleted out of there. Discontinued the donepezil related to side effects, probably not. And then start this new drug. So what is most likely happened is this physician has gone and gotten involved in one of those sit-down luncheons and been exposed to this drug, gotten new information. So I implore you to look up that medication and see what it's doing and see if you can utilize it as well. I have not, I don't know enough about it. Your TSH has improved. Your Synthroid is at 88 micrograms. Follow up on TSH. Well, your TSH is ordered on 5-8. So you could even write in 2 days because again, it's a blanket snippet and you can add it. Monitor for manifestations of hyperthyroidism, which means her thyroid is down in the 0.001 category. And we already know from up here that her thyroid was 4. So we're not monitoring for hyperthyroidism. So we're going to just take that out. And then requested appointment, follow up appointment with endocrinologist. And let me just see if he had a follow up included. follow up in 2 months. So follow up with Dr. Lebrano in 2 months. A lot of the times we say follow up, can't get a schedule, get a schedule, get a schedule, and then we realize, oh, they've already had a schedule. So appointment with neurologist, April 24th. This needs to be discontinued. They've already had the appointment in there. Yes, you're monitoring all of that stuff. So left humeral fracture, no pain, brace and sling off, delete that out. Followed by Dr. Ortho, it doesn't, or Dr. Nash, it does not say following, get an appointment, etc. And then under here, it's specifically saying the UTI is colonized, try to avoid additional antibiotics at this time, completed ertapenem related to E. coli. So this was a patient that was on ertapenem, imipenem, Rocephin, doxycycline about twice a month. And so she just needs to get off the antibiotics. So that's why that's on there. Okay, so we've got a review of labs, you've got a lab ordered, you've got a note completed, and then you're collaborating with a lot of people. You're not only discussing what's going on, but you're also having the patient being followed by it. So the patient is a moderate degree of medical decision making. I'm deleting that out. This patient, because I spent a little time with her, this patient is going to be a high degree of medical decision making. I'm going to use this. Patient has a chronic illness with severe exacerbation. Period. So that's the snippet I've chosen to use. And then I'm going to use that new snippet that I added. This visit meets criteria for high MDM. Gotta put it right before my dictation. Related to a high-risk diagnosis, which was deteriorating, as well as data reviewed, including labs reviewed, labs ordered, and review of progress notes in collaboration with staff. So parts of this note were dictated. So I'm going to go ahead and follow up, finish this note, knock it off with a 99310. Again, you can see that the HPI is pretty extensive. It goes over a lot of things, but then I also met that criteria based on my labs reviewed, ordered, progress note reviewed, and collaboration with staff. So you want to improve your notes, take 5 extra minutes, increase your HPI, add a couple of things that they have orders for or that have changed, and then you can get to a 99310. Pretty easy. If you have any questions, you can call me, text me, email me. It's Saturday morning. Maybe I need a nap. Have a great day.